Hospitals are cornerstones of their communities, serving as principal access points to care for the nearly 60 million people, or 20% of Americans, who live in rural areas. Despite their importance, rural hospitals continuously confront a multitude of challenges that threaten their ability to ensure local access to care. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Netterly, senior writer at AHA and your podcast host. Recently, AHA published a rural report titled Challenges Facing Rural Communities and the Roadmap to Ensure Local Access and High-Quality, Affordable Care. This podcast series is built around the rural report, meaning it highlights a rural health challenge and shows how the field responds to the call of action.
Today, we examine the challenge of behavioral health services for rural Americans, and our experts will share an evidence-based model to increase access to mental health services, as well as an evidence-based practice to integrate behavioral health services into primary care clinics. Dr. Carrie Henning-Smith is an assistant professor and deputy director at the University of Minnesota Rural Health Research Center in Minneapolis. She's here today to describe a toolkit that hospitals and health systems can apply when addressing mental health services in rural areas. We're also joined by Shelley Ravello, Director of Integrated Care at J.C. Blair Health System in Huntington, Pennsylvania. And she's here to share how they have integrated mental health care services into primary care settings and why it is vital for the best patient outcomes. But first, let's review the challenge. Recent evidence suggests that many behavioral health conditions disproportionately affect rural communities, and these trends are especially alarming in light of the fact that more than 60% of mental health professional shortage areas across the United States are rural or partially rural. Carrie, please tell us about your efforts at the University of Minnesota Rural Health Research Center for supporting organizations implementing mental health programs in rural communities.
Of course, and thank you, John. Here at the University of Minnesota Rural Health Research Center, we developed a toolkit of evidence-based models and information to help healthcare organizations nationwide address the issue of increasing access to mental health care in rural America. This toolkit was funded by HRSA's Federal Office of Rural Health Policy, and it's freely available online on the Rural Health Information Hub website for anyone who'd like to look at it. The primary focus of the toolkit is adult mental health, and it includes 7 different modules, which include information on the background of mental health in rural communities, different strategies that communities can use to address mental health concerns, and information around evaluation, sustainability, dissemination, and all of the other tools that you need to successfully address mental health in rural communities. Module 2 of the toolkit highlights 6 innovative program models offering a variety of different potential solutions to addressing mental health conditions in rural areas. These models were chosen based on research showing their effectiveness, as well as to highlight a broad array of potential options for addressing mental health in rural areas. They include prevention and community education, workforce recruitment and retention, emerging leaders in mental health, telehealth, integration into primary care, and community-based supports and services.
Great. Thanks very much, Carrie. Now, when we say that the toolkit is evidence-based, what is it that we mean by that?
We mean that there is research behind each of these programs to support their effectiveness, to support the fact that they can actually work to improve mental health of individuals and of communities.
And then what would be the first steps that hospitals can take in implementing one of these models?
The first step that any hospital needs to take in implementing any of these models is to first look around and understand the need. And the best way to do that is to make sure that you have the right people at the table. You need to have clinicians and other staff from the hospital, but you also need to make sure that you have individuals from the community who are stakeholders in this issue and understand what already is happening and where the gaps remain.
That's fantastic. So the focus here is on primary care, which is an important model for rural communities. And as mentioned in the rural report, behavioral health, including mental illness, emotional distresses, and substance use disorders, they disproportionately affect rural communities. For example, CDC reported that suicides in rural areas occur at much higher rates than those occurring in more urban areas. And in addition, rates of substance use disorder and drug overdose deaths in rural communities are notably on the rise, surpassing rates in urban areas. Shelley, can you tell us why you applied these approaches to your work at J.C. Blair Health?
I would be glad to, John. We received funding from HRSA's Federal Office of Rural Health Policy to implement mental health programs to expand access to the healthcare services within our rural community. As a hospital-based healthcare system, integrated behavioral health was a creative blend of services, but it was really what our health system needed at the time. While our health system has since changed since our pilot project, our community needs have remained the same. And like national data suggests, patients' emotional health needs were being addressed within the primary care setting, but often this approach did not provide adequate assessment or services. And this was true in our community as well.
So tell me then, how does J.C. Blair then work to integrate these services into its primary care clinics?
So the first thing that we had to do was to choose a model of integrated care that would fit our healthcare system in our community, and of course that was evidence-based. We chose to use the primary care behavioral health model, or the PCBH model. Through this brief intervention model, we then apply evidence-based practices, including cognitive behavioral therapies, motivational interviewing, and screening tools designed to screen for many different mental health conditions, but including anxiety, depression, trauma, and substance use.
Now, you mentioned that the project brings together a collaboration of medical and mental health groups. Who are they, and how did you accomplish that?
So as Carrie mentioned, it's critical to have the support of key stakeholders in the development and the implementation of the program. We were really fortunate to have a lot of support along this journey, and it really did start with a lot of our local partners who we had worked with before, internally and externally. For this project, we had support from obviously our own healthcare system and our affiliate at the time, which was UPMC Pinnacle, but we also partnered with Juniata Valley Drug and Alcohol Abuse Commission and Juniata Valley Behavioral and Developmental Services, which supported the drug and alcohol and the mental health side of our community from a local government administration practice side.
Can you tell us then how it's going so far? Are there any preliminary results or reactions in the community or with patients that you can share?
Yeah, absolutely. Our program is in a constant state of program development, but the Integrated Behavioral Health Program has demonstrated so far the ability to make a positive impact on our patients, our providers, and the overall health system. For example, we have satisfied patients who believe their care has been enhanced through our services. We have healthcare providers who have expressed gratitude for supportive services to assist their patients with aspects of care that they could not. We also have demonstrated the ability to manage healthcare costs within our healthcare system by identifying the most appropriate level of care for patients. We've seen this also by influencing representation to the emergency department and supporting patient treatment plans to improve patient retention within the practices.
That's excellent. Thanks very much. Carrie, what kind of traction do you see the toolkit getting across the nation?
We know that the toolkit is getting great traction. The folks at Rural Health Information Hub website track analytics on it, and the toolkits as a whole, there are toolkits on a variety of different topics, got more than 300,000 hits in the last quarter alone, which is fantastic. That said, I still think there are a lot of people and health systems in rural communities that are not aware of the toolkits, and I'm happy to spread the word about them. They're an excellent resource.
So you mentioned RHI Hub, which is www.ruralhealthinfo.org for those toolkits. Shelley, tell us a little bit then about the lessons you learned and advice you might be able to give other hospitals and health systems from your great work.
I think that J.C. Blair was able and willing to take a risk on an emerging trend in healthcare, which has actually now become a standard of care across the nation. And it's been really exciting to see this change happen. And I would really encourage hospital systems to think of alternate ways that they could address the patient needs. We tend to be in a very traditional model. Unfortunately, healthcare systems are changing all the time, and so are the demands of our patients. So integrated care is able to respond to that in a way that can help the patient level and the system level. So it's definitely worth a risk to take for a little bit of extra investment and time and resources. And there are ways to find those resources, whether it be within the system as a cost savings way or whether to look for alternative funding.
We know that recruitment and retention of healthcare professionals is a continuous and an expensive proposition for most rural hospitals. And the clinical workforce shortages exist across most specialties, but the limited number of behavioral health providers is particularly striking. How do we address this? How, as a field, can we do more to improve access to behavioral health services in rural areas? Carrie, what advice can you tell us?
Well, I think the example that Shelley is providing is a really wonderful one and could be a good starting place for a lot of rural hospitals that feel like they still have room to improve in this area. The more that we can move mental health care into primary care settings and out of being siloed only within behavioral health or mental health specialties, the more we can help to improve access to care. We know that there is a greater supply of primary care physicians in rural areas than there is of mental health specialists. But we can also think creatively about ways to use telemedicine to connect remotely with specialists when specialists are needed, and also to think about other professions who might have a role here, including community health workers, social workers, nurse practitioners. It's an all-hands-on-deck approach when we're dealing with something as big and complicated and important as mental health.
And Shelley, how do you bring that to Huntington, Pennsylvania and Juniata Valley?
It definitely takes a partnership and it takes road mapping to know where the end game and what your outcome wants to look like. But the strategy to get there definitely takes some planning. And we've been able to do that as our program has changed by working with our local FQHC, which is Broad Top Area Medical Center. And as our system has changed in the community, Broad Top Area Medical Center has been able to allow us to work with them within the primary care setting. So we never lost traction with the program implementation. It shifted a little bit, but the model remained the same. And being able to do that within a primary care setting, we were able to piggyback on the resources that were also within their system. And so that traditional care team was then expanded and enhanced. You mentioned about the challenge to recruit providers, and I know that that's obviously a real shortage here in our area as well. An integrated care approach does allow us to find an alternate way to get around the traditional silos that Carrie was talking about, because a lot of patients don't actually need to seek treatment and specialty mental health care. They seek that from their primary care, but the primary care system needs more support. And so by working together to identify the appropriate provider and train and mentor them, you're able to create a system that can address those patients' needs right where the patient is already getting care.
Thanks for listening, and thanks to Shelley Ravello and Dr. Carrie Henning-Smith for sharing their work. If you want to learn more about the work that AHA is doing to improve access to care in rural communities, visit us at www.aha.org. I'm Tom Hedderly, and this has been Advancing Health, a podcast brought to you by the American Hospital Association.